Hey guys, hi. This is Barbara Garcia back here with chapter 14 for Path 370 to talk a little bit about blood coagulation and the coagulation cascade and some of the diseases associated with it. All right, so what is hemostasis, right? Hemostasis is basically stopping blood loss, right? So we want to prevent blood loss after a blood vessel has been injured. This would be as simple as getting a paper cut, to as complex as, lancing through an entire blood vessel, like maybe even somebody who's trying to commit suicide, right? So, obviously it's getting through the blood vessel wall, and it's going to involve the circulating platelets and their ability to clot that particular area and to stop it from bleeding, right? So if hemostasis is inadequate, you're going to continue bleeding. If hemostasis is excessive, you might see clotting and thrombosis. Right, so primary hemostasis is the initial response to vascular injury, right? So that first thing is going to be constriction. So injured vessels constrict to prevent blood loss, right? After the vessels constrict, right, you're going to see formation of a platelet plug. A platelet plug is going to involve the exposure, right, from the injured vessel, exposure of like the collagen fibers, and platelets are going to be attracted to those collagen fibers, and they're going to accumulate, and eventually they're going to stop up that particular cut, right? Then secondary hemostasis involves the formation of a fibrin clot, right? So you have two pathways, the intrinsic and extrinsic pathways, and these are the ones you want to make sure that you know. That leads to something called coagulation. Then the final stage is the retraction of the clot. So when you have a blood clot or fibrin clot, then you need to break down the fibrin clot as the tissue below it is healing. And it's critical for those two things to be able to happen, right? So what are platelets? So platelets are a type of cell. Well, let's make sure we understand that they are a cell that has a fragment of a cell that has come off a larger cell, remember, called the megakaryocyte, right? So they basically are collagen exposed trauma to a particular vessel. That's what the platelets are going to be attracted to, right? They become activated and degranulate, releasing alpha granules and dense bodies that are going to start to form that platelet plug, right? Then secondary hemostasis is going to be very important in fibrin formation, okay? So you can see here, there's no platelet factors being released here. However, in your damaged collagen, right, you're going to see that the activated platelet is now going to adhere to it, and then it's going to recruit more platelets and bring forth the fibrinogen, which is going to eventually be converted to fibrin, and then it's going to block off the blood exposure and blood release through this endothelium. All right, so most, right, of the plasma proteins are found in the blood in an inactive state. So they're made by the liver, but they are not going to be activated until they are called forth through either the intrinsic or extrinsic pathway, right? We have an standardized nomenclature for those different proteins in that cascade. Okay, so the numbers, they're usually numbered, right, with Roman numerals, and then they have a letter next to it, an A if it's been activated. All right, so for example, factors 2, 7, 9, 10, protein C and S are dependent on vitamin K for synthesis. So vitamin K is one of our fat-soluble vitamins, and it's very important that we receive adequate amounts of vitamin K, right? A lot of our bacterial flora in our colon make vitamin K, but we do consume some vitamin K, and we want to make sure that we have sufficient in order for those factors to be activated and to be working properly. Antithrombin 3 and protein C promote anticoagulation, like heparin enhances actually antithrombin 3. Then protein S and assists the protein C in binding to phospholipase and stimulating the release of plasminogen, tissue plasminogen activation, right, which is a initiator of fibrinolysis. So I don't know if you've ever heard of tissue plasminogen activator. It's also referred to as TPA, and TPA is a very strong clot buster. I've heard it in a lot of little scenarios where in the hospital you might need TPA to break a clot. But you have to be really careful when you have a patient with a clot, because TPA really, since it's going to function in the coagulation cascade by basically blocking, right, and or starting fibrinolysis. It's going to, if there's already a clot forming, it's basically going to stop it from forming. So if there's a cut anywhere, you're going to have lots of bleeding, like excessive bleeding. And we don't want excessive bleeding, especially if a patient's already in a situation in which they are in a, like, mildly stable. So if they've been stabilized in a hospital, you don't want to unstabilize them by having them bleed out. Okay. So, the action of, heparin, right? So, right, antithrombin 3, right, is going to block, right, inhibits the activity of thrombin, which kind of makes sense, right? And then heparin, right, which is an anticoagulant, is going to block the activity of this antithrombin. Remember, thrombin is part of the coagulation cascade, so antithrombin stops clotting, and then heparin is an anticoagulant, so it's going to stop that from occurring. All right, so the intrinsic pathway is initiated, right, when blood encounters or comes in contact with this exposed collagen from damaged endothelium, right? And then the extrinsic pathway is when the vascular wall is traumatized, like in a crush injury. So the extrinsic pathway may not be activated if the tissue, so this is from the tissue, this is more from the blood, right? And so if the tissue is not also affected, right? So they both basically are going to lead into the common and final pathway where prothrombin is going to be activated into thrombin, and then eventually thrombin is going to catalyze the reaction of fibrinogen to fibrin, and we have a fibrin clot. And this is called the coagulation cascade. And this picture here is actually on page 298 of your textbook, and it is figure 14.4, and you definitely want to make sure you know this. This is all anatomy and physiology. Okay, so it's physiology, but I guess more than anatomy, but it is all there. So what I want you to see is the intrinsic pathway. I want you to notice that it says PTT. So your measurements on your laboratories, like your laboratory reports, are going to say PTT and PT, especially, of course, if they're worried about whether or not these patients are coagulating properly, right? So they may not test that if that's not a concern of theirs. But if it is, they would include that, especially if somebody's having surgery. They want to make sure that the PTT and PT times are appropriate, right? So PTT is going to be measured from a measurement of the intrinsic pathway. The extrinsic pathway is measured as PT, okay? So one way to remember that, what I've always looked at is let me see if I can write on here. Okay, so PET, okay, so maybe not line for him, right? So PET, and then you put pit bull, right? And then E for PT, right? Is the extrinsic pathway, and pit, forget the bull, but pit, but you say pit bull because it makes more sense. Pit with the I, that stands for the intrinsic pathway. So it's PTT. So there's two T's in your pit bull. Right? So that was kind of a cool little way that I've always used to remember the intrinsic and extrinsic pathways. Okay? I want you to notice also that there is an enormous amount of calcium that is going to be utilized. Well, not enormous amount, but calcium is used at pretty much every step in order to activate this pathway. So I've already said many times that calcium is probably the most important of our electrolytes. Remember that it also works in your heart, and it rushes in, right, and is going to help you cause contraction by binding to troponin and making the active sites available. Does the same thing in skeletal muscle. Actually helps with exocytosis in the neurons, and then helps with the blood coagulation cascade. I'm thinking that calcium and regulation of calcium in the blood is critical for all of those functions, which are obviously very important. All right, so you can see there some of the different homeostatic mechanisms. So, for example, inhibited by protein C for factors 8 and factor 5. And then you can see here some of the platelets, and then the common pathway, and then the platelets and how they are going to either call forth the intrinsic pathway, and then the tissue here area is going to call forth the extrinsic pathway. So it's a really good coagulation cascade summary. So you might want to make sure that you go back and look at that one again. All right, so fibrinolysis then is going to be clot dissolution, or dissolving the clot, right? So occurs as the fibrin clot is forming. We also want to have, right, these plasminogen activators that are going to take plasminogen, form plasmin, and then basically begin to digest the fibrin clot, right, by inactivating factors 5 and 8. Remember, we had talked about it here. 5 and 8 exit by protein C. All right, so eventually, right, the fibrin split, right, products result from the dissolution of the fibrin clot, and then you're going to keep a balance between clot formation and clot dissolution. Remember, it's all about maintaining the right amount, but not over excessive and not under. All right, so here you can see fibrinolysis, right? The plasminogen activators take plasminogen, which again is released by the liver and is floating freely in the blood, and it's going to convert it into plasmin, and then plasmin is going to start this process of fibrinolysis, kind of degrading the fibrin clot. All right, so included usually in patient history, physical exams, clinical assessment, and lab tests. Remember PTT and PT, so PET, pit bull. So PET, P-E-T, tells you that the extrinsic pathway is measured by PT, the functionality of the extrinsic pathway, and P-I-T-T in pit bull is going to measure the intrinsic pathway. So I think that's a really cool way to remember that, right? So determine if the problem exists, and then do something about it if it doesn't work the way it's supposed to, especially looking for things like family history of bleeding. So I don't know if you guys have talked about it, but the hemophilia gene has been historically a very relevant gene, right? Because it actually was found among the monarchs in the Queen Elizabeth from England, and when she had her children, she passed it down to many of her children, and many of her children were then kind of shipped off to the other monarchs to marry, because remember, this is all like royal blood. You want to keep royal blood, and it's kind of ironic because the royal blood had this genetic defect, right? All right, so I was talking a little bit about family history, right, and Queen Elizabeth, right, and so obviously family history of bleeding may lead you to understand that that this might run in a particular family. Hemophilia is X-linked, so usually the mother, like Queen Elizabeth, passes it down to her male children. So basically, you know, all of the monarchies of the entire Europe, like even Prussia back in that day, they all fell because all of the males ended up having this hemophilia gene, except the British monarchy, which is the only one that currently exists, right? So that kind of you can see how that family history is really important. And then active bleeding, right? That is unresponsive to standard interventions. Screening before surgery. So I'm sure that you've had that question asked. So have you had surgery before? Part of the reason why they might is so that if there's anything of difficulty clotting, that we know that, and that's noted in your chart. Then also things like if you've had a reaction to anesthesia, that's also really important. So surgery and questions that may indicate any prior history for bleeding or any other concern during surgery is obviously important to keep track of. And then ongoing evaluation of therapies that are anticoagulative. As you can see here, clues from patient history, right? So family history of bleeding in both males and females might lead you to von Willebrand disease, which is a different type of cause that is not going to be related to hemophilia A or B, which are going to be primarily X-linked. So these are obviously more of a recessive gene, right? And then newly acquired bruising might lead you to think that maybe they're on drugs, especially aspirin, since it also does prevent some coagulation from occurring. And then other anticoagulant therapy, or that person has thrombocytopenia, so they have low thrombocytes. And then excessive bleeding or bruising after surgery, you might see von Willebrand disease is another possibility, or some deficiency or mild deficiency of other coagulative factors throughout that cascade. So it's important to understand that cascade, right? And then bleeding following initial hemostasis. So you have hemostasis in the beginning, but then you are going to then see afterwards a bleeding, then that might indicate factor 13 deficiency. All right, so again, very important, right? Systemic diseases can be involved, or aspirin. This is why they always tell you to cut off aspirin, right, before getting a surgery, to kind of prevent that anticoagulative effect, right? So it could indicate history of anticoagulants, you know, chemotherapeutic or thrombolytic agents, or maybe even non-steroidal anti-inflammatory agents, right? Like, you know, ibuprofen or so on. Right, so some hemostasis clinical or signs that you might look for: pallor, right, or jaundice, hemarthrosis, so bleeding into the joints, telangiectasias, which are going to be bundles of blood vessels, right? So especially if you see kind of bundles of blood vessels either in the skin or in the mouth. Petechiae. Remember, petechiae are those little bitty red dots, right? And purpura, ecchymosis, which basically is bruising, and hematoma, which is like a raised bruise, right? So you can see they're petechiae, little red dots, right? That could indicate the vascular, the vessel lining is kind of not properly holding back the blood. So you could see that it's widespread. It's not just one or two dots. It's quite widespread. So that's definitely something to add to a report if that is visualized on your patient. Purpura, which is sort of like a little bit worse than the petechiae. You can see that it's kind of merging together. Definitely something that should be noted. And then telangiectasias, those are the bundles of blood vessels, okay? On the skin, they appear like this child's here on this picture. And then other things, nasal drainage, or even hemoptysis, or bleeding through the nose, right? And excessive menstrual bleeding. These are other things that could, even in history, or hematuria, hematemesis, right? And then even the fecal matter. So you might see occult bleeding, or hidden, right? Bleeding, or even frank bleeding. Like that's going to be nasal drainage if it's coming straight from the nose. Epistasis, and it's bloody, right? That's something that needs to be noted. Some people with high blood pressure occasionally will have, you know, nasal drainage of excessive amounts of blood. Right, so then the first and laboratory tests, right, are going to indicate a primary and secondary hemostasis, right? So the complete blood count is going to be used to look at that remember, hematocrit number, that's going to identify anemia, or hemoglobin concentration number, that's going to identify some type of anemia. And then platelet count can also help identify your ability to clot, that particularly that platelet plug. And then you're going to see the PT and PTT times as well, and your laboratory values. So those laboratory values are important, right? So sometimes a smear, right, might indicate, right, the appearance of platelets and their platelet function, right? So again, the D-dimer also can be used for fibrinolysis, but the PTT and the PT-INR ratio, right, is going to indicate both the, right, PT, the extrinsic, and PTT, the intrinsic pathway, like I mentioned before. All right, so question 1, a 4-year-old boy is brought to the emergency department after taking an overdose of his babysitter's NSAIDs, so non-steroidal anti-inflammatories, right? He found in her backpack. Which of the following laboratory tests would be abnormal? Right, so think about that, and then we'll see if we come back to the question. All right, so platelet count is not going to be altered, so I'll give you that one. It's not A. All right, so then vascular disorders, right? So a primary cause of bleeding is a problem with a vascular component of a primary hemostasis. These could be both acquired vascular disorders, and you also have some inherited or genetic vascular disorders. All right, so vascular purpura is an abnormality of the blood vessels or supportive tissues where you will see purpura, right? Those are the petechiae as they kind of run together. You might see allergic purpura as well. And then Ehlers-Danlos syndrome is a deficient collagen. They have a defect in the collagen. There are like 8 different types of collagen. So Ehlers-Danlos is a deficiency in like type 4 collagen. Whereas I don't know if you are familiar with osteogenesis imperfecta. That is actually a defect in collagen, in type 1 collagen. So the different types of collagen, and Ehlers-Danlos makes people really stretchy. So I don't know if you've ever seen these people. They're like super stretchy because they have a deficient collagen. They're going to have the elastic fibers being, so they have super stretchy skin, super stretchy joints and stuff like that. So they can hyperextend their joints and stuff of that nature. A vitamin C deficiency can also prevent collagen synthesis, right? And so these are going to affect and the lining of the blood vessel and the connective tissue. And then aging, obviously, losses in both either subcutaneous fat and or connective tissue that can also indicate and show up as vascular purpura, right? So the purpura, depending on where it is located, it might be, might help you figure out what is the causative agent, right? So the causative agent, right, of the vascular purpura, right, could be used in testing. So there's one test, the tourniquet test, right, may be used where basically the tourniquet test is basically when you place like a blood pressure cuff, for example, and then you basically run it for about 5 minutes and then look and see if petechiae have appeared as a result of it. If this is like an allergic vascular purpura or something like that, then avoiding obviously the causative agent would be the main thing that you would seek to do. Then another hereditary hemorrhagic telangiectasia is an autosomal dominant trait. Remember that autosomal dominance, you only need to receive one gene from one parent in order to get the disease, right? So you'll see small dilated blood vessels that bleed very easily, and these are the some of the telangiectasias that you might see having epistasis, a lot of bleeding from the nose and things of that nature, right? The vessel wall is composed, right, of a very thin layer of endothelium. So if there's a lot of them, they can definitely break, right? So repeated episodes of bleeding, treatment is basically supportive. There's really not much that can be done since it is a genetic disorder, cauterization or iron replacement for excessive blood loss, maybe laser therapy, right? So other platelet disorders, right, can lead to or appear as an abnormality in the quantity or quality of patients, right? So maybe acquired or inherited, right? So thrombocytopenia is acquired, and it's usually an immune-mediated disorder, right? So that it is basically going to be either persistent, newly diagnosed, or chronic, which is going to be over 12 months, right? So you can see thrombocytopenia is low number of thrombocytes. So you have decreased production or decreased platelet survival. Splenic sequestration, so the spleen is kind of holding and keeping a bunch of these thrombocytes, and sometimes they can affect the spleen and the ability for the spleen to do its job. And then intravascular dilution of circulating platelets. So you can see some causes of thrombocytopenia, right, including cancer in the bone marrow, right? You might see chemotherapy and drug use, right? Some increased platelet survival. You might see, viral and bacterial infections, including drugs like thiazides, right? Furosemide, which are both diuretics, right? And then disseminated intravascular coagulation, DIC. And then you might see splenomegaly and hypothermia as well. So those, bone marrow suppression can obviously cause you to make less thrombocytes, right? Immunizations, or even alcohol ingestion can cause you to not clot properly. Okay, so you might see prolonged bleeding time, petechiae and purpura. And so treatment is based on whatever cause it is. If it's bone marrow suppression from chemotherapy, maybe switching the chemotherapy drug, right? Immunizations might just be supportive until the body adapts, and then maybe make a note for future immunizations, like maybe in a child or something of that nature, right? So thrombocytosis is the opposite, where you have too many platelets, right? So greater than 400,000. It could be due to stress, physical exercise. Also could be to polycythemia vera. Polycythemia vera, remember, is an increase in the red blood cell line. And so since your megakaryocyte is on the myeloid cell line, right, that's really important for you clinically, because obviously too many platelets, right, can cause clotting, right? And then chronic granulocytic leukemia you might also see for the same myeloid lineage, right? Remember, myeloid and lymphoid. So the myeloid cells make pretty much all of the granulocytes and all of your red blood cells and megakaryocytes. And then it also can be in response to hemorrhages or disease processes or splenectomy. So if a spleen has been removed, you might see excessive number of platelets, right? So it may bleed or clot. Okay, so that really is depending on which type you might have and what is the origin of it. So basically, cytotoxic agents are going to be trying to lower the number of cells, right? An antiplatelet or interferon therapy. If it's transitory, like it is due to an immune response, to an immunization, excuse me, then you might wait to see if it passes. All right, so a patient is found to have tiny spots on the skin of his upper legs that are not raised and do not pale with pressure, right? So tiny spots, right? So what are tiny spots? Those are going to be petechiae. Remember, epistasis is bleeding or discharge from the nose. Purpura is those larger kind of purple looking petechiae when they kind of all run together. And ecchymosis is basically just a bruise. Right, so the quality of platelet disorders. So if the ability of platelets are not, doing their hemostatic job, is because you can have adhesions or aggregations or the release is abnormal, you're going to have an inability for proper blood clotting. So some inherited disorders include the Bernard-Soulier syndrome and von Willebrand disease, and even thrombocythemia. All right, so acquired disorders are more common, like drug-induced or due to renal failure. And so you might see the petechiae on the skin and the mucous membranes, epistasis, gastrointestinal bleeding, and menorrhagia, right, or menorrhagia, and that's, you know, excessive bleeding during your period. All right, treatment is based on the underlying disorder and may require platelet transfusions. Coagulopathies are actually quite a big group of disorders, and they are basically some defect of the normal clotting mechanism, right? So bleeding, right, from with the formation or lysis of the fibrin clot, right? So that there's some in the pathway, there's a problem, or it's due to the inactivation of the coagulation cascade. So hemophilia is probably the most commonly inherited coagulation disorder, so you absolutely have to know it, right? So hemophilia A is a factor 8 deficiency, and then hemophilia B is a factor 9 deficiency, right? So hemophilia, you're going to have hemarthrosis, so that means that there's blood in your joints, right? So in the patient or family education, or even asking questions first. So you want to know a little bit more about the family history, right? And then after the family history, you might look for treatments that are appropriate for the type of hemophilia that it is. So for example, you might want to give a lot of factor 8 for those in hemophilia A. So you might have to have multiple blood donors take basically just their plasma, isolate factor 8, and then administer it to your hemophilia A patient. That's how most hemophiliacs deal with this disorder, right? And then same thing for hemophilia B. You might have cryoprecipitate of factor 9 for hemophilia B, or fresh frozen plasma. Von Willebrand disease, right, is another really, really important disease. It's autosomal dominant, which means if your parents have it, you're more likely to have it. Remember, if it's X-linked, your mother carried it, but only the males in your family are going to be affected. In autosomal dominant, there's probably one person, either your mother or your father, who already have it, and then the child has it without skipping a generation. That's usually autosomal dominant. I mean, it could be recessive, but autosomal dominant has a 50% chance of being passed down to the child. And then recessive is neither one of the parents may have it, but the child may have it, and that's because they both carry the recessive gene. So let's make sure you know, the autosomal dominant, right, and autosomal recessive, and how those are passed down, right? So basically, it's a disorder of the factor 8 carrier protein, and basically resulting in platelet dysfunction. All right, so prolonged bleeding time. And so prolonged PTT time, right? And then you might see normal platelet count, though, and a normal PT-INR, which is the international normalized ratio, right? So one of the main treatments for von Willebrand disease, right, is desmopressin, right? So basically helps release the von Willebrand factor and factor 8 from the vascular endothelium. So you might also see cryoprecipitate. It's used to manage, and Humate-P used to manage severe bleeding. And then, of course, since aspirin does increase bleeding time, you want to avoid aspirin use for people who have confirmed von Willebrand disease. All right, so vitamin K deficiency. Remember, I told you that vitamin K is really important in coagulation factors 2, 7, 9, and 10. So if a patient is vitamin K deficient, you might see excessive bleeding. So they might see intracranial bleeding, even hematuria, right, in the blood, melena in the poop, or you have, you know, the kind of that brownish appearance of blood in the stool, and then your umbilical bleeding, and even hypovolemic shock if that enough blood loss has occurred, right? So administration of vitamin K in the newborn. right, is really gonna help eliminate this coagulation disorder. And fresh frozen plasma might be necessary in case that your administration of vitamin K is not sufficient, right? So sometimes people acquire, due to malnutrition, acquire vitamin K deficiency. Remember that vitamin K is often made by our bacterial flora in our colon. So if you have malnutrition, you might have very little or a poor colonic flora, because obviously you are such malnutrition that these colonic flora have died. So it is a fat soluble vitamin that of course can be supplemented if consumed, but if you have already problems with malnutrition and not eating, then you're not eating the vitamin K wherever it's in the food that it's found in, right? Then you might see hepatic disease or antibiotic therapy as another way of having acquired vitamin K deficiency, and maybe oral anticoagulative therapy results in excessive bleeding, right? And then so you'll see the PT-INR increase, but other coagulation studies are all normal. So when you see PT-INR increase by itself, you're going to see that. So then some of the treatment, right? Parenteral administration of vitamin K, and then treat basically the underlying condition. And then disseminated intravascular coagulation is a hemorrhagic syndrome, which is acquired usually due to trauma or malignancy, abruptio placentae, which if the placenta has basically abrupted, and then your clot formation is going to be seen in small vessels, right? Clotting factors and platelets consumed, right, in resulting in bleeding. So you might see bleeding because the clots are found, so instead of the clotting factors being able to stop your bleeding, you're going to have clotting factors all clumping throughout your body. So in essence, right, you have intravascular, so inside the blood vessel coagulation. So then when you cut, you're not going to be able to see that, right? So disseminated or DIC, disseminated intravascular coagulation, is going to usually be triggered by something, maybe a high fever, an infection of some kind, a blood loss of some kind, activation of the coagulation cascade, leading to microthrombi. And so once all of these activation of the cascade causes these little microthrombi and emboli, you're going to have vascular occlusion, and then consumption of the clotting factors, and start fibrinolysin. So because you have the occlusion of the blood vessel, you might have ischemia to the organ. The consumption of all the clotting factors in these microthrombi leads to excessive bleeding, and then fibrinolysis starts to then continue the bleeding, and so you lead to a type of shock because you're excessively bleeding called hemorrhagic shock, right? So fibrinogen level and platelet counts are usually decreased. You have an increased bleeding time, and then elevated PT-INR and PTT. Right? And then D-dimer and fibrin split products are also going to be elevated. So you see that you have fibrinogen levels and platelet counts decreased, but everything else has basically been increased. Right? So if there's a cause, remove it. If not, right, supporting of major organs, fresh frozen plasma, right, platelets, and then maybe use of heparin to further consume the clotting factors is sort of a controversial type of treatment because it kind of feels like it's making it worse, but eventually what it's trying to do is really kind of regulate. Remember, let the homeostasis try to take over. Hepatic diseases, right? So hepatic disease can result in coagulopathies, right? Because of vitamin K absorption or impaired absorption of vitamin K. You have, fibrinogen factors 5 and 9, right? And then you have an inability to remove the activated coagulation factors, leading to thrombocytopenia. All right, so hepatic disease can also cause this type of coagulation disorder. So this is usually treated by vitamin K administration and fresh frozen plasma or whole blood. Right, so which disorder causes a patient's body to clot and bleed at the same time, right? And so we just talked about it. That's DIC, disseminated intravascular coagulation, because you're clotting, and then because you're doing these microclots inside of the blood vessel, then you're going to bleed because it's not available to clot the blood out of the hole in your blood vessel. All right, thank you. That's for chapter 14. I'll see you again for chapter 15 for next week.